Hi guys, we're going to talk about Chapter 38. This is the nursing care of the child with an alteration in intracranial regulation and neurological disorders. This is going to encompass a lot of those neurological problems that we can sometimes see in our patient population. So let's get started here. When we look at intracranial regulation, this really refers to the process that affects equilibrium in the brain and the patient's neurological function. Intervention is key as nurses. If we don't intervene quickly, we're going to delay those life-threatening complications that can happen. So we've got to intervene quickly, we've got to recognize quickly, and then we need to do something fast to prevent some of those complications. Intracranial regulations do have devastating and lasting impacts on our families. Family support is going to be vital throughout the course of this illness and beyond. As nurses, we need to be familiar with those neurological conditions so we can provide prevention, treatment, guidance, and support for our families. The brain and spinal cord make up the central nervous system. Development of these structures typically starts at 3 to 4 weeks gestation. Infection, trauma, teratogens, and malnutrition can cause physical defects and may affect normal central nervous system development. At birth, the cranial bones are well developed, but they are not fused. Therefore, there's a higher risk for fracture. The brain is very vascular, which makes it a high risk for hemorrhage. The fontanelles, we've talked about those, are present when in the newborn, and this really helps that skull be more flexible and helps accommodate that brain growth. Closure too early or too late could really indicate problems with brain growth. The child's spinal cord is mobile and continues to be at high risk for cervical spine injury. The nervous system is complete at birth, but very immature. Myelinization, or the formation of myelin, proceeds in a cephalocaudal direction, so the infant is able to control the head and neck before the trunk and extremities. And this slide here just shows you those proportions of head to body height. You can see in that newborn, right, our head is quite large, and then we kind of grow into our head by the time we're 6 years old, and then even more as an adult. So assessment is the first part of our nursing process, and assessment of our neurological exam is going to include inspection and observation. The nurse is going to assess that cerebral function while performing a physical examination. Remember, we want to perform our assessment from least invasive to most invasive. So we're going to inspect and we're going to observe before we palpate or start touching. The use of toys or familiar objects is going to help promote that cooperation with that child. When we think about level of consciousness, we can use our Glasgow Coma Scale. That is a 3-part assessment. We're assessing eyes, verbal response, and motor response. The highest score is 15, and that's an unaltered responsive patient. The low score of 3 means we're less responsive, and that child is worse off. 3 is the worst possible score on that scale. And you can see that scale there in that bottom right corner. As we continue talking about levels of consciousness, there are 5 states of consciousness for our pediatric patients. That is full consciousness, confusion, obtunded, stupor, and coma. And you can see there that each of those have a definition of what each of those exactly means. So just be familiar with each of those states of consciousness. As we continue doing our neurological exam, we look at our vital signs. So we have to think to ourselves, what vital signs would help us assess if neurological issues are present? We can think about oxygenation. So no or little oxygen to the brain can really alter that patient's level of consciousness. We can also think about fever. If fever is left unattended or it's too high, it may cause seizure activity, which could be harmful for the brain. When we look at our head, face, and neck, we're looking for shape and symmetry. We're also checking our head circumference. Why is that head circumference so important? We know there's a strong relationship between the head and brain growth. So getting those documented measurements each time is going to allow us to see if our head is staying the same and what's going on, or did it get really large and are they having some other issues? Cranial nerve is that alteration in a cranial nerve function, and that can be the result of a compression or a specific nerve, infection or trauma. So we want to note the pupil size. If they're dilated but reactive, sometimes we see that with our seizure kids. If they're pinpoint, we might be concerned about a brainstem dysfunction. And if we have one eye that's dilated but the other isn't, that may indicate some type of a mass is going on. We also want to know if they have any sunset eyes. So that's that picture there below. You can see where it looks like the sun is setting, right? The eyes are kind of on that lower part. That is an indication of increased intracranial pressure. We also want to look to see if there's any nystagmus, which would make us think there's some type of brainstem function. When we look at our motor function, that includes muscle strength and tone. The top picture there on the left shows the decorticate and decerebrate posturing. So decorticate posturing might mean there's a cerebral cortex damage. Decerebrate posturing may mean there's a brainstem damage. Both types of posturings are characterized by extreme rigidity to those muscles. We can also look at reflexes, and we've talked a little bit about these in our infant growth and development chapter. So just be aware that all reflexes typically disappear around 3 to 4 months of age, except for Babinski, which should disappear around 1 year of age. Sensory function is what it is, right? We're testing the function of our sensories. So can they distinguish between light touch, pain, heat, or cold? And then we're going to move into palpation. So we're going to palpate those fontanelles. And this is really important part of that neurological exam. A bulging fontanelle can be a sign of increased intracranial pressure. It's very normal, though, for the fontanelle to be bulging if your infant is crying. So make sure we take that into consideration. If they've been nonstop crying for a few minutes and you feel that fontanelle's bulging, give them some time to relax and see if that goes down. Neurological disorders where bulging fontanelles may be seen is our hydrocephalus children or anybody that might have some head trauma. So as we look at managing our disturbed sensory perception, we want to assess those changes in sensory perception, monitor the child for any risk, right? If they don't have the ability to distinguish between heat and cold, they may step into a really hot bath, or they may burn themselves washing their hands because they just don't have that sensory perception. So just making sure that we're aware of that risk for injury. And we want to notify the provider of any changes. And I think that's the biggest takeaway from this slide is if you see a change in sensory perception, make sure you notify that provider as soon as possible. So what are some of the types of neurological disorders we might see in children? We can think about structural disorders, seizure disorders, infectious disorders, trauma to that neurological system, blood flow disruption disorders, and then our chronic disorders. So we're going to touch on just a few of these here. What are some factors that we can think about that affect our neurological diseases as we look at the nursing process to care for the child with that neurological disorder? We start with that assessment piece, which includes that health history. So some of the factors that we want to hit on are prematurity. So premature infants can be at risk for capillary rupture in the brain, which can lead to intracranial bleeds. We also have to look at the history of their birth. Was it a difficult birth? Did they have birth asphyxiation, meaning inadequate oxygen supply before, during, or after the birthing process? Or was there any infection during pregnancy that can really give us an indication of those neural tube defects? So some common signs and symptoms that we might see that are related. We may see some nausea, some vomiting. We may see some headaches, usually very early in the morning, but they become very frequent and persistent. You might see changes in gait. The first neurological disease process that I can remember way back in my nursing career was a patient coming in just for a well child exam, and the mom commented on how his gait was a little abnormal. So the provider had him walk down the hallway, and he clearly had a change in gait. And come to find out, we did some additional studies, we sent him for some diagnostic testing, and he had a mass in his brain. So just again, those common signs and symptoms, just being aware of those. Do they have any loss of motor function, visual disturbances, change in level of consciousness, increased irritability, or even that altered muscle tone? So some common labs and diagnostics that we can think about. We can definitely do a lumbar puncture, and that's just analyzing that cerebral spinal fluid. So where we're going to withdraw cerebral spinal fluid, it's going to check for infection, maybe or obstruction. We can also do an intracranial pressure measurement that can monitor the pressure intracranial. So hydrocephalus, head trauma, brain tumors may have that monitoring happening. Our electroencephalogram, or EEG, is just that electrical activity of the brain. It can determine if there's seizure activity or if they have any brain death. We can do head and neck radiography, so x-rays of the skull and spine structures to check for fractures. It can give us some information on ICP, and it can detect any skull defects. Ultrasound is those sound waves, maybe can interpret some intracranial hemorrhaging going on. Fluoroscopy is that live, up-to-date radiography. So if there's any cervical spine instability during movement, it can note that. Cerebral angiography is an injection of that contrast. If there's any vessel defects, we can see that. If there's any space-occupying lesions, we can see those. When we think about CT, MRI, PET, or that SPECT, those are just different measures of our brain, tissues, compositions, functions, things like that. So common medications used to treat neurological disorders are listed here, and there's a great chart on page 13, 41, and 42 in your book that lists each of these medications with the action, indication, and nursing implications. But we can think about antibiotics, anticonvulsants for seizures or hyperexcitability, benzos, analgesics for discomfort or pain, osmotic diuretics if we need to reduce that fluid that's on the brain, and then some corticosteroids, which can help with any inflammation or edema. Medical treatments for neurological disorders. This can be found in your book on page 13, 40, and 41. There's a great box that states each of these treatments, why we use them, what they're indicated for, and what those nursing implications are for each of them. When we think about our ventricular shunt placement, those are usually used for our hydrocephalus patients, and it's that catheter that's placed in the ventricle of the brain. The CSF can drain down to the peritoneal cavity. You can also see atrial shunt placement, which is that CSF is draining to the atrium of the heart. Typically, you're going to see the ventricular shunt placement, though. The VP shunt is the most common. Hyperventilation can definitely decrease our CO2, which results in vasoconstriction and decreases our ICP. Different therapies that can be seen improve motor function, so PT, OT, ST, external ventricular drainage. Again, that's pretty similar to our shunt, except that it's on the external part of our body. So it's that catheter in the ventricle that's draining that CSF to some type of external reservoir. We can do a ventricular tap that reduces the accumulation of CSF. Vagal nerve stimulator is that stimulates programmed to stimulate that vagus nerve. So usually you'll find those like on the top of their chest, and you touch it and it really just kind of stimulates that vagus nerve. A lot of time you'll see this with our seizure disorder patients. And then ketogenic diet is a relatively new one. This can also help with our seizure kids. So high fat, adequate protein, low carb can put them in a ketosis state. So mild dehydration helps prevent, control, and reduce our seizures. So why a ketogenic diet? It's going to help control and reduce that seizure activity, especially if they're very hard to control. So just remembering that high fat, adequate protein, and low carb puts them in that ketosis state, which helps control those seizures. So this slide here just shows you some pictures of those things we were just talking about. The top left one is their shunt placement. It's that catheter that's running from the ventricle of the brain, and it's running down into that peritoneal cavity to alleviate some of that fluid buildup in their brain. So you can see the extra CSF in the ventricle, and then they place that shunt, that catheter, and that is able to disperse some of that extra fluid. The bottom left is that vagal nerve stimulator. Again, it's kind of in that top upper chest area, and we can touch it. It just kind of depends on the nerve stimulator. Touch it, vibrate it, and it's just going to stimulate that vagal nerve. And then your external ventricular drainage there, same concept as the shunt. It's just going to that external device. So prenatal risk factors include prematurity, maternal drug or alcohol use, maternal infection, maternal teratogens, and that fetal malnutrition. And we've kind of already hit on that, some of those risk factors of these neurological issues based on what happens with birthing and how the mom takes care of herself during her pregnancy. So let's move into epilepsy. Seizure disorders are the most common neurological dysfunction in children. Epilepsy is a condition in which seizures are triggered recurrently from within the brain. If we define epilepsy, that's greater or equal to 2 unprovoked seizures. Single seizures are not generally classified as epileptic and are not treated with long-term medications. So we want to see greater or equal to 2 unprovoked seizures. The prognosis is typically very good, and many children are going to outgrow this epilepsy. Some may have some persistent seizures that are difficult to manage, but most children are going to outgrow them. We need to do a really good assessment on the risk factors, checking their health history, doing a physical examination, and checking for labs and diagnostics. Therapeutic management of epilepsy is going to include on focusing on controlling the frequency of the seizures, healing the child, and teaching the patient and family how to live with a disorder. They will probably start some anticonvulsant therapy, and you can see that listed on your anticonvulsant medications in your book. As far as nursing assessment, it is rare to observe a child having a seizure, so getting a detailed history is essential from the parent, right? The parent's going to see the seizure at home. They're going to throw them in their car or call 911. By the time they get to you, you're not going to still be observing that seizure. So making sure you get all the details is essential. As far as nursing management, we want to make sure we're preventing any injury during the seizure activity and making sure we're administering some medication to help eliminate that seizure that's going on, and then providing our education. Seizures could have a very devastating impact on the quality of life of our child and family, so making sure we're doing lots of education, medication education, injury prevention education, knowing the signs and symptoms that you may see prior to a seizure coming on. Other types of seizures that are common are epileptic spasm or infantile spasm. And this is an onset that can happen in the first 6 to 8 months of life. There's some degree of cognitive impairment. Usually they have a very poor prognosis for mental and development if they have these that develop. Absence seizure is that brief loss of consciousness, minimal to no change in muscle tone. It's typically a childhood disorder, usually 4 to 12 years of age. And we have that sudden onset. They can have up to 20 per day. And a lot of times this is misdiagnosed as just being inattentive or daydreaming. Tonic-clonic, tonic meaning stiffening of the muscles, clonic meaning repeated jerking motion. And this is usually often associated with an aura. Their entire body experiences that tonic contractions followed by rhythmic clonic contractions, alternating with relaxation of all of those muscle groups. Myoclonic is a sudden brief contraction of muscle groups. There's no loss of consciousness. It often occurs with falling asleep, and it may be mistaken for an exaggerated startle reflex. Atonic is that sudden momentary loss of muscle tone. Usually the onset is 2 to 5 years. They often fall to the ground and often on their face. And then status epilepticus is that seizure that lasts for more than 30 minutes or a series of seizures without regaining their level of consciousness. Febrile seizures are very benign in nature. They are typically done by the time the patient arrives in the emergency department. So again, you're not going to see it. It's usually seen in children less than 5 years of age. The peak is usually between 12 and 18 months. It's more commonly seen in boys than girls, and it usually occurs with a temperature greater than 38.8 degrees Celsius. The seizure occurs when that temperature increases. So what can we do if the patient presents with that febrile seizure? We want to make sure we get a fever reducer on board, make sure if the seizure is still ongoing that we're controlling it with some diazepam, and then just evaluate the history of the child and the seizure activity. So some common types of structural defects that we're going to hit on. We're going to look at neural tube defects, microcephaly, Arnold-Chiari malformation, hydrocephalus, intracranial arteriovenous malformation, and craniosynostosis. So let's just get started with each of those here. So when we look at our neural tube defects, we can think about ancephaly is that first one we're going to talk about, and it's a defect in the brain development resulting in a small or missing brain hemisphere. Most of these infants are born stillborn, or they die within hours to several days after birth. The infant is usually born blind, deaf, unconscious, and unable to feel any pain or discomfort. Nursing management includes just supportive care for the family, explaining to the family what to expect when they see their infant, maybe placing a cap on the infant so that the parents are allowed to feel more comfortable holding their infant. Encephalocele is a protrusion of the brain and meninges through a skull defect. Therapeutic management is going to include surgical repair, including placing some of that tissue back into the skull and removing the sac. Nursing management is going to focus on pre and post-op care, prevention of rupture or infection, and adequate nutrition and hydration. Infants with encephalocele are at high risk for developing hydrocephalus, so we want to make sure that we're monitoring for any signs and symptoms of increased intracranial pressure. Microcephaly, so this is a head circumference that is more than 3 standard deviations below the mean for age and sex of the infant. And I think we all can remember hearing about kind of an increase in microcephaly due to Zika virus. That's probably the most recent. It generally is going to result in intellectual disabilities due to a lack of just that brain tissue functioning. There's really no treatment for microcephaly, and nursing management is going to include supportive care and focusing on the extent of any neurological or cognitive functions that may be impaired. Chiari malformations are classified into two different groups and subgroups based on the anatomical anomalies. Type 1 is usually not associated with hydrocephalus, and it's more benign. This type is typically seen in adolescence or adulthood. Patients will complain of neck pain and recurrent headaches that worsen with activity. And you can see in the picture there at the top, the Chiari malformation, where you can see that cerebellum is displacing into that upper cervical canal. So you see the normal one on the left, and then you see that cerebellum kind of sneaking down into that upper cervical canal on the right. So that's type 1. Type 2 is the most common and is usually associated with hydrocephalus and myelomeningocele. Type 2 is almost always associated with that myelomeningocele, so it's detected prenatally or at birth. Since hydrocephalus is a complication, most of these patients will have a shunt placed. Therapeutic management of type 2 is going to be surgical decompression, and nursing management is going to really focus on our pre and post-op care, prevention of infection, monitoring any blood loss, and then making sure we're identifying any of those signs and symptoms of increased ICP. Hydrocephalus is not a specific illness, but it's really a result from an underlying brain disorder. It is an imbalance in production and absorption of CSF. So there's going to be a lot produced, and then they have a hard time absorbing it. So CSF accumulates within the ventricular system. If the head becomes enlarged, and we have increased ICP. Clinical manifestations can vary from infants versus children. When we think about our infants, that they have that frontal enlargement, their head is larger than their face, they have that translucent skin, their side is palpable suture lines, and they have those bulging fontanelles. So you can see that infant pictured there, and you can see a lot of those signs and symptoms. Clinical manifestations with our children are usually depressed eyes. They have those sun-setting eyes, like we've talked about. Remember, sun-setting is that just indication of increased ICP. So you'll see those sun-setting eyes. The pupils are usually sluggish and unequal response to light. They may complain of headaches and nausea. Nursing management is going to focus on just maintaining that cerebral perfusion, making sure we're minimizing any neurological complications, making sure they have adequate nutrition, support, and education. So what's the goal of treatment for hydrocephalus? It's going to be surgical placement of that ventriculoperitoneal shunt, so our VP shunt. The focus is to prevent any further accumulation of that CSF. The shunt's going to bypass the blockage and drain the fluid from the ventricles to an area where it can be more readily reabsorbed into the circulation. So how do we monitor for improvement of hydrocephalus? We can definitely check our head circumferences. Fontanelle tension should decrease, and ultrasound is going to show a decrease in that ventricle size. So if our patient does have a shunt, we do need to be aware of signs and symptoms of any shunt infection or malfunction. So making sure we're aware of each of these signs, because it's very important for providers, nurses, families to be able to recognize these signs when our shunt may need to be replaced because of complications. Remembering that shunts are treatment for hydrocephalus, but they don't come without these complications. Complications can include an elevated vital signs. They can have more poor feeding. If they're having projectile vomiting, that can be a definite sign. And when I say projectile, it's not just spitting up, it's shooting across the room. They may have decreased responsiveness, seizure activity. You may even see signs of local inflammation along that shunt tract. This is an emergency, so making sure we know these signs and symptoms. Increased ICP can occur, which is going to lead to worsening neurological status and altered LOC and eventually death if we don't recognize these signs quickly. So let's talk a little bit about intracranial arteriovenous malformation. This is a rare congenital disorder, and it's caused by an abnormal development of blood vessels in the brain, brainstem, or spinal cord. So you can see just all of those blood vessels are accumulated right there in that brain. So this is our intracranial arteriovenous malformation. The most common symptoms that are seen include intracranial hemorrhage, seizures, headaches, vision problems, loss of speech, and paralysis. Diagnosis is made using imaging procedures such as CT, MRIs, or arteriography. Nursing management is aimed at supportive care and monitoring for any changes in neurological status. So what are we trying to prevent with this malformation? And that's going to include hemorrhage that could lead to stroke. Craniosynostosis is a premature closure of those cranial sutures. Premature closure can inhibit brain growth and distorted skull appearance. Surgical correction may be done to allow for normal expansion. Nursing management is going to focus on that post-op care, observing for any pain, hemorrhage, fever, infection, or swelling, making sure large amounts of facial swelling could occur is going to inhibit that child to open their eyes or their mouth. And then really making sure that we're educating our family and being that supportive system for them. So you can see in the picture there, same child, pre-op, you can see the cranial sutures were closed. They opened him up, and he's just having that more kind of normal-ish looking development to him. The skull is less distorted, I should say. All right, so let's look at some infectious disorders. The different types that we can look at are bacterial meningitis, aseptic meningitis, encephalitis, and Reye's syndrome. So when we look at bacterial meningitis, we need to remember that this is an acute inflammation of the central nervous system. Infection of the meninges is what we're talking about, and that's that lining that surrounds the brain and the spinal cord. This is a medical emergency and requires prompt hospitalization and treatment. Deterioration is rapid, which leads to that neurological damage. The list on that right side of the slide lists the physical findings that you might see with patients diagnosed with bacterial meningitis. Some common symptoms might include headache, photophobia, so the bright lights are harmful for their eyes or discomforting for their eyes, vomiting, they may have a stiff neck, and remember these symptoms may come on very suddenly. Nursing management is going to include prescribed antibiotics after obtaining cultures, initiating supports. They may need oxygen, they may need prevention for injury to that brain, and they will be in isolation precautions. Typically, they're going to be in droplet precautions from those nasopharyngeal secretions. Lumbar puncture is our definitive diagnostic test. So which vaccines, when we think about this bacterial meningitis, there is a vaccine that can prevent this, and that's our Hib vaccine, HIB, and pneumococcal vaccine that are given in infants. We also see that meningococcal for our adolescents before they head off to college. The other one I really want to touch on is Reye's syndrome. Reye's syndrome is a rare disease, and it primarily affects those children younger than 15 who are recovering from some type of viral illness, meaning they've had chickenpox, they've had croup or influenza. Reye's syndrome is a reaction that is triggered by the use of salicylates or salicylate containing products. So aspirin, Pepto-Bismol are those products that we would not want to use. It can cause brain swelling, liver failure, and even death. Common signs and symptoms that are reported typically include continuing vomiting that is severe, changes in mental status, lethargy, irritability, confusion, and hyperreflexia. Early recognition and treatment is important to manage this illness. Nursing management is aimed at maintaining that cerebral perfusion, managing and preventing increased ICP, and providing safety measures due to changes in LOC. Patients and family need to be educated on the important aspects of prevention, and this includes educating that salicylate products cannot be given to children. So that includes aspirin, that includes Pepto-Bismol. Those products should never be given to a child, or they could develop this Rise syndrome. Early and late signs of increased ICP are listed here. We've talked about a few of these, so just be aware of what are my early signs of increased ICP and what are my late signs where my patients going to deteriorate quite quickly. All right, let's move into some causes of head trauma. So head trauma is a broad term that can include specific patterns of injury. Common causes include falls, motor vehicle accidents, pedestrian or bicycle accidents, and child abuse. When we think about child abuse, it's that violent shaking, it's those blows to the head, that intentional impact against the wall, furniture, or floor. So nursing management of that child with head trauma is going to really depend on the seriousness of the injury. Caring for the child with mild to moderate injury is defined as a brain injury without any penetrating injury to the brain. There's no loss of consciousness, and there's no other injury to the head or body. These patients can usually be managed while at home, provided the parents and caregivers have clear instructions regarding the care of that child and what symptoms to watch for that would constitute seeking medical treatment. Caring for the child with a more severe injury can range from temporary unconsciousness that resolves quickly to children who may remain comatose for a prolonged period of time. Prioritization of care is going to focus on airway, breathing, circulation, neurostatus, and pain. When we think about our closed head injury, again, it's going to depend on the severity. Mild, moderate, or severe is going to base your symptoms. Again, this can occur with an accident. It can be an intentional injury. This usually is a non-penetrating injury to the head, and normal behavior is occurring before the injury, and they may or may not lose any of their consciousness with these. So non-accidental head trauma is definitely the leading cause of traumatic death and morbidity during infancy. The infant's head is really large. We've talked about that quite frequently, and they have those weak neck muscles, and that's going to place them at increased risk for that head trauma. Causes are going to include violent shaking, blows to the head, intentional cranial impacts against a wall, furniture, or floor. Nursing management is just being aware of those risk factors, education, early recognition of any suspected child abuse is essential to prevent death and disability from repetitive inflicted head trauma. So when we think about blood flow disruption or cerebral vascular disorders, we think about strokes. So these do occur in children less often than in adults, but they are still an important cause of mortality and chronic morbidity in our kiddos. Two major types of cerebral vascular disorders are ischemic stroke and hemorrhagic stroke. Ischemic being more common in children. Common signs and symptoms are going to include weakness or one side of hemiplegia, facial droop, slurred speech, and speech deficits. As nurses, our focused care is going to be on assessing that neurological status, increasing their mobility, providing adequate nutrition and hydration, and encouraging self-care. Rehabilitative services may be warranted depending on those long-term deficits. As we start educating our patients and family, just remember these points. Make sure we're assessing the willingness to learn. If they're not willing to learn, it's probably not a great time to start teaching. So hit them when they are willing to learn about this. Remembering there's a period of time when they get the diagnosis, they need that time to process before they want to learn about it. Provide that family with time to adjust to the diagnosis. We may need to repeat the information multiple times. Teach in short sessions and make sure we're giving the most important information at the front end of those short sessions. We need to gear that teaching to the level of understanding of the child and the family, provide reinforcements and rewards, and then use multiple modes of learning. That's going to use lots of different senses. And that concludes Chapter 38 regarding intracranial regulation. If you have any questions or concerns, you can shoot me an email or we can chat about it in class. Thanks, guys.